I presented this talk at the Kentucky Orthopaedic Society, geared toward the University of Louisville and University of Kentucky residents, and also the faculty that attended the meeting October 2017 at the Galt House. The talk is entitled Sports Medicine Through the Arthroscope and Camera, 30 Years of Practice. This is my experience over the last 3 decades. I am Mary Lloyd Ireland, professor at the University of Kentucky, orthopedic surgeon. View through the lens, reflections. I started taking pictures many years ago, as you can see in the lower left photograph, with my Brownie camera at the Capitol, Washington, D.C. You can see the dates based on the cars and also how cute I looked as a 8-year-old. That was a big highlight in my early life, being in D.C., touring, and maybe that's when I got a camera bug. Later on, doing a lot of sideline coverage, I continued my passion to take pictures. I had a better spot than the photographers in the box on football sidelines, so I kept on looking through the lens, so to speak. And I've enjoyed taking pictures of animals, birds, and athletes throughout the years. It's a great way to find passion. If you like taking pictures, go for it. Our University of Kentucky orthopedic residents are now covering football sidelines and doing sports medicine. Hands-on. I think this is a very good way to build your practice. It gives you confidence in your diagnostic skills without hiding behind MRI scans in your offices. You have to be able to communicate, determine quickly whether to let the athlete who is injured go back in the game. So I would encourage our young orthopedists to do this during their residency. It's the best way to develop your practice. Once you get into practice, you serve the community. It's free advertising, and it really is fun. You can reach many generations, the players, the coaches, their parents, grandparents. These are our residents, Wilson, McQuarrie, Unger, and Zacharias, with the athletic trainer at Henry Clay on the right. View from the sideline. I enjoy working and taking care of injured athletes, but if you're not working and you're not busy and you want to do something like I like to do on the sidelines, I enjoy taking pictures. So if you're not working, why not take pictures? We really do have the best view. What about the beginnings of arthroscopy? If you think about it, the arthroscope, much like the camera, has made significant advances. Arthrotomies were done, and we looked in joints and fixed things that way. Unfortunately, stiffness was a problem. So why not make smaller incisions? If you look at the history of orthopedics and arthroscopy, it's a very interesting story. 1918, Professor Takagi was the first to use the cystoscope in a cadaver knee. So this was the beginnings of arthroscopy in the East. Then a more familiar name to us, Dr. Watanabe, developed the arthroscope in 1951, and he named them or numbered them with the advances. And in 1958 was the first truly successful arthroscope developed by Dr. Watanabe. What about in the West? In 1921, Jacobius did a laparoscope and put it into the knee. At that point, CO2 was used for distension, so we did gaseous distension and not water distension. This gas distension was popularized by Dr. Bircher. Dr. Michael Burnham at HSS introduced the 4 mm diameter arthroscope into every joint in human cadavers. But there were some pretty interesting cadaver dissections and discoveries of what we could see through the scope as opposed to looking at it directly by arthrotomy. With World War II, from 1939 to 45, the advances stopped in arthroscopy. This is a discussion with Dr. Robert Jackson, who is in the middle, with the East, discussing cases with Dr. Watanabe and Dr. Ikuchi in Tokyo. Another thing that dates this photograph is that everybody's smoking in 1964. Great pioneers with vision that allows us to be able to do the arthroscopic techniques that are now standard in our orthopedic armamentarium. So look how far we've come from the looking through the scope directly with our eyes many, many years ago. In 1982, this SEBA Clinical Symposium on Diagnostic and Surgical Arthroscopy was written by Lanny Johnson, who too was a pioneer in advancements of motorized equipment and motorized burrs and arthroscopic treatment of the shoulder and the knee. And then on the right, I'm scoping a knee. We have made progress with the video cameras, the clarity, what we can see, what we can do arthroscopically. Got to keep up with all these advances and also know the history of how the arthroscope was developed and keep on asking questions and looking back at history. So this was 1985, a scope, what the scope looked like in the shaver. You can see how things have gotten smaller and more efficient from 2005, where we have a smaller scope, better quality picture. So what's happened in the generation that I've been in practice? Prior to 1985, this was when I was a resident, what we were able to do is extra-articular reconstructions. We couldn't address the anatomic injury and put it back because we didn't have the equipment nor the visualization. So before arthroscopy, we did things open. Extra-articular reconstructions of the shoulder, subscapularis transfers, coracoid transfers, capsular shifts. Sounds familiar to now 2017 in that we're doing a lot of this arthroscopic or arthroscopically aided with mini open techniques. So back then, our coracoid transfers were a Bristow. Now it's a Latarjet, which is a variation of a coracoid transfer. Sometimes we use the coracoid. More than often, we use an allograft. And also we address the capsule and repair the capsule back anatomically and then use that bone transfer technique in severe anterior instability cases. What about the knee? We did IT band tenodeses and medial repairs for ACL, MCL, knee dislocations. Another popular procedure was a pes anserine transfer, popularized by the orthopedists in Oregon many, many years ago. This was done in an extra-articular. We didn't really address the ACL at all. Knees got stiff. They didn't remain unstable. We stabilized the knee, but they were stiff, and so when you have a 10-degree flexion contracture of the knee will develop arthritis even though it is stabilized. And now look, in 2017, we're back to IT band tenodeses. There are different techniques that can be used, but this is being used as a backup for a failed ACL reconstruction, and basically we do an anatomic ACL reconstruction with a graft of choice, usually the patient's own tissues, bone, patellar tendon, bone, quad tendon, or hamstrings. Put it in the right place, but there are certain patients who may need more lateral stability. Usually repairs don't work of the ALL if that exists, so we do some form of a tenodesis, again extra-articular, to reduce the pivot shift. What about the ankle? Today we try to address the capsule, address the ligaments directly, doing modified Brostrom repairs, which is more of an anatomic reconstruction. Prior to the mid-80s, we did a lot of peroneus brevis transfers. This stabilized the ankle, but it was extra-articular and actually over-constrained the subtalar joint, and some people got too stiff and developed subtalar osteoarthritis. So after 1985, anatomic repairs and reconstruction were started via arthrotomy, then arthroscopy, and the arthroscope paved the way for advances in surgical techniques and understanding mechanism of injury, particularly in the shoulder when we made diagnoses of slap tears, labrum tears, and prior to the early 80s we didn't really understand the labrum and how it is injured in the throwing athlete. So we started doing scopes, figured it out, and went back to the mechanisms of injury. So these are some pictures when I was a fellow at the Houston Clinic in 1985. Upper left is an arthritic varus knee, medial compartment gonarthrosis, and you can see this bone on bone. What did we have available in the 1980s? Dr. Houston popularized this high tibial osteotomy, which we did a closing wedge high tibial osteotomy, took a piece of bone out, put them into valgus. This was the so-called Coventry method described by the Mayo Clinic orthopedic surgeon. But what we fixed it with, we just had a third tubular plate, bent it, and put a big screw in, and that was our fixation. You look now, we have a lot of different grafts that we can use to do now our opening medial wedge osteotomy instead of a closing. And we can put in synthetic bone graft, a lot of different fixation techniques, which are very expensive, much more expensive than our third tubular plate and a big screw. We've come a long way from extra-articular to intra-articular anatomic reconstructions. We did a lot of manipulations in the 80s where people got too stiff. This is shown in the lateral side on the upper left here. So this was our IT band tenodesis. This person got very stiff, so we're doing an exam under anesthesia and a closed manipulation. We didn't scope him, now we would re-scope him. So he got much better range of motion after the manipulation. This was an arthroscopy, so we took out scar tissue, arthroscopy, and then did the manipulation. And then this is a very huge hunk of ectopic bone from medial collateral ligament pull-off off the femur, Pellegrini-Stiata syndrome. Stiff knees, and we have come a long way with emphasizing range of motion, regaining range of motion, and I think we're doing a much better job with anatomic reconstructions. This is an individual with a knee dislocation. We don't see this a lot, but it is still missed in our ERs. If you have someone who has an exam on the field that opens up in extension, varus or valgus, you've got to think ACL, PCL, and a knee dislocation. And in those cases, you do want to get them to an emergency room that can assess their vascular status. So this was a football athlete who had a valgus blow. You can see in the upper right, this is a positive suck sign that we coined. So the skin is actually sucked into the joint because that's all what is attaching. Only the skin is stabilizing him medially. Had an ACL tear, PCL tear. After making a skin incision, no further dissection was necessary. This is the meniscus that's in the breeze there. The deep capsular ligaments, meniscofemoral, meniscotibial, superficial tibial collateral ligament are all detached from the meniscus. So do a direct repair of that, ACL reconstruction with bone patellar tendon bone autograft, and we did repair the PCL back to the femur, and the patient did very well. So when you see dimpling of the skin on your exam on the field, you got to think nothing's left here. Patients don't hurt if they have a complete dislocation, typically acutely, because there's no distension of the joint possible with the hemarthrosis because everything leaks out. As you can think here, there's nothing to contain the blood, so there's no pain. So what's the arthroscopic view in 1990? This is what it looked like. You young orthopedic surgeons should be very happy and blessed. Look back at some of these pictures. We were able to do arthroscopy, but it was a bit more painful to do because we couldn't see very well. So this is our shaver in the 1990s, And then this is osteoarthritis of the patella and trochlear groove. We did more aggressive removal of spurs and debridement in those days, but they got stiff. So we now know that arthroscopy for arthritis is not indicated and patients don't do well. There are indications for arthroscopy in arthritis if they're loose bodies, and sometimes people can have a lot of arthritis and do very well. So this is our Lanny Johnson Schlesinger clamp to remove a big loose body. And then this is arthrofibrosis. This is a burr, so we did do abrasion chondroplasties in those days, hoping that we would get better ingrowth of articular cartilage, but again, that didn't work, so we don't do these procedures anymore. And if you look at it, it's kind of hard to see, but we got through it and we did a good job in those early days of arthroscopy. This was in 2000, debridement of a stiff knee, arthrofibrosis. You can see all the synovial tissue, the scar in these. The scar comes from the synovium. Fat pad becomes very fibrotic. And so, again, an aggressive removal of all this tissue and a manipulation is done. Fortunately, we're not having to do as many of these because we don't see arthrofibrosis, perhaps because we've changed our prehab, work on range of motion, get the knee more silent and normal before operating on them. More to come on what the biochemical reasons, genetic reasons for arthrofibrosis of any joints. This is a picture of the notch using a rear entry guide for a ACL revision that was done in 1990. Here's the screw from the previous ACL. So you have to find a way to have a different angle on your femoral tunnel. Obviously this one was way too central or too vertical, but we used a rear entry guide, and there are others that have been developed now. There are guide systems where you can go outside in or inside out. When you're doing revisions, you need this. This is still a good way to find your spot for a revision. And this shows the rear entry guide and the pin coming in. Not the greatest view, but that's what we had. And you young orthopedists are somewhat spoiled because we've got greater views and a lot better equipment. Hunter in 1743 stated with articular cartilage, as you can see down here on the right, once violated, articular cartilage defects are a troublesome thing. They don't heal. So we're still trying to develop ways of early diagnosis and how to treat these. Microfracture isn't working in large defects. More research to come and advances and hopefully getting this able to heal in a way arthritis does not occur. It's a bad day when you have an ACL reconstruction and you have this big large defect. What do you do with that? As of now, we do a microfracture, knowing that that will not give us the best articular cartilage nor normal collagen type, but that's what we start with, and push range of motion, limit their weight bearing for 4 to 6 weeks. What about shoulder pain in a thrower? In the history of taking care of this, prior to the 80s, before we had arthroscopy and before we had MRI scans, there was no diagnosis of a slap. No labrum tears were really diagnosed except for instability. And when you had anterior instability, the Bankart lesion did include the labrum and the anterior inferior glenohumeral ligament. So prior to the 80s, anterior shoulder pain was biceps tendonitis. In 1990, slap lesions were described. In the 1990s, we repaired most of these, and then we saw so many failures in people after the age of 35, our overhead factory workers, the repairs didn't work. 2005, things changed where we made more diagnoses of slap tears, but we repaired less. And you definitely don't repair them as you get older because they don't work, so after age 40. So when we do scopes, we either leave the tendon alone, do a tenodesis to soft tissue, put the tendon into the proximal humerus, or do a tenotomy. So we repair less as we get older. Well, after age 40, and even in our young throwers, slap tear repair may not be successful. Biceps glenoid labrum complex. Before 1985, there were many procedures that were described. Originally, Hitchcock and Bechtel in JBJS 1948 observed the painful shoulder. The role of the tendon, the long head of the biceps, is its causation. Now, 69 years later, the biceps is still a pain generator. We're still trying to figure out what to do with it. Hitchcock described a keyhole tenodesis, which basically we're using variations of this now with our arthroscopic or mini techniques, subpectoral tenodesis. Know your literature. Don't make the same mistakes. Hitchcock had it right. What about shoulder instability? The extra-articular techniques of tendon transfers, coracoid transfers. We now do Latarjet procedures. In the 70s and 80s, we didn't have scopes, so we would do a Bristow-Latarjet or a Bristow-Helfet, which was a coracoid transfer, and we really didn't do as much to the capsule as we just created a bony block that unfortunately made the shoulder very stiff and wasn't the best thing for athletes who had to have full range of motion. Now we do intra-articular techniques, capsular shifts, Latarjet, open or combined. And these combined intra-articular and extra-articular techniques for severe instability seem to be working much better. Descriptions of these, of the Bankart Latarjet, Bristow-Latarjet procedures are below. And again, you can see these are very old articles, but classic, and describe the anatomy, what happens at the time of dislocation, and what different things we can do to fix it. Latarjet, original article in 1954. What happens with the Bristow? I did a lot of Bristows training in Southern California. That was the west side of the country, east side of the country in Boston. Dr. Carter Rowe and the surgeons at Harvard in Boston popularized Bankart. Sometimes the screw would break, so this is taking about an inch, 2.5 centimeters coracoid tip and putting it anterior inferior. Again, this was all extra-articular. Sometimes there were non-unions. In general, the shoulder was stiff and stability was restored, but these were over-constrained and ended up with glenohumeral osteoarthritis down the road. Hardware is never an easy thing to get out either, and sometimes this broken hardware is not symptomatic if the coracoid fused on the neck of the glenoid. Beware prominent hardware in the shoulder. It can break, it can erode things. Lanny Johnson developed this staple for repairing the capsule of the shoulder, but as you look at the head of that staple, it definitely erodes into the articular cartilage of the humerus, causing glenohumeral osteoarthritis. So these metal implants were not good around the shoulder. I was fortunate enough to never use them, but this was the new low-profile staple in the 90s. Sometimes this staple works well if you have a bony avulsion of the tibial eminence with a skeletally immature individual, but not in the shoulder as originally described. Loose bodies. This is a picture of a scope done in the late 80s. You can see this big loose body. Loose bodies tend to go down into the subscapularis recess, so if you're looking for a loose body, that typically an instability comes from the lip of the glenoid, and it can get to be pretty big, so this was a pretty big loose body. Usually they're not symptomatic, but if you see one on MR or plain films, you want to get it out, so it'll tend to hide subscap. It'll go down to this subscap recess and be way down here, so get a big grasper, Schlesinger grasper, remove it, and you'll have a better picture than this from 25 years ago. Instability surgery in the 90s. This is a picture of Dick Kasperi, and Dr. James Andrews. Dr. Kasperi developed this punch where basically this is the front of the shoulder. The shoulders, we're in the lateral decubitus position. This is the humeral head. So you can see here the pathology from anterior instability hasn't really changed much, but what could we do arthroscopically in the 90s? We didn't have any way arthroscopically to put anchors in directly into the glenoid. These weren't developed yet. We didn't have ways to pass sutures. So what did we do? This was a suture punch. So we would put this instrument in and put the sutures through the front of the shoulder, and then we would take a beef pin and pass these sutures from front to back through the scapula and tie them down. It was a bit scary because we were playing cowboys and Indians and putting this big pin through the scapula. I never had any complications such as lung tissue or infection, but it was a bit of concern when we did that. And then we would tie these sutures, so the loops were here, and then the suture ends were in the back. We would tie them over the musculature of the scapula, and then that would cinch or bring this capsule back to the glenoid. And the principles then were to look and try to prepare that bed and get the loose bodies out and make sure you had a good bleeding bed on the glenoid, and then bring that patulous capsule back to the front. So again, we've come a long way, and we have a lot cooler, easier tools and equipment to use. Make sure you use things that have been tried and true. Don't put metal around the shoulder or any prominent heads that might erode the humeral head. So this was a transscapular Kasperi suture technique. Look it up. It's very interesting. Dr. Kasperi was a great role model and an inventor of many things about the shoulder. He thought outside the box. Buddy Savoie was fortunate enough to train with Dr. Kasperi and look at the things he's done and invented. Mentors are great. Talk to them while you can. This is a device called a SureTac. This was kind of cool in the late 1990s. This was about all we had too for anterior labral tears. So this was made out of an absorbable material, kind of, PLLA, but the prominence of the head, sometimes this thumbtack, so to speak, would break off and be a loose body. But in this individual, so here's the labrum, glenoid, and this was great tissue, so it was nice because it was very efficient. You just put a guide wire in and then drilled and passed this over and hammered it in, and for certain cases it worked pretty well. It was only to reattach the labrum. You couldn't bring any of the capsule with you there. So this is the anterior-inferior labrum with the anterior-inferior glenohumeral ligament. So this was more of an acute case, and this worked in some individuals, but we've come a long way, and now we've got much better ways to address and anatomically repair and do capsulorrhaphies and capsuloligamentous repairs. Thermal shrinkage came along. That was a technique where we hoped by putting a thermal device on the tissue, it would shrink it just enough. This was a hope for multidirectional instability patients such as swimmers. Unfortunately, when we heat up tissue, we kill it. So this thermal shrinkage is not done now, and it was not successful, and in fact caused some problems with taking out too much capsule or dead capsule. So my own personal experience was with bacon. So if you think about the capsule, there are different thicknesses of the capsule based on genetics or how many times you've had anterior dislocations. And in the upper left, this one piece of bacon pulled out, and then you got a thicker piece of bacon and a doubled over bacon. You can see how with the different seconds, 30, 60, 90, 120. So if you left that thermal probe on too long, you definitely fry the tissues. Some things never change. One is exam under anesthesia. You always want to get a good exam under anesthesia of knees and shoulders. Do it supine, and then I do my scopes in the lateral decubitus position, examine the normal, and then go to the injured side. And this is particularly important when you're learning how to examine and what the subtleties are of instability. So this is an anterior instability case, and I'm levering the humeral head out the glenoid applying an anterior directed force on the upper left, and then up on the upper right, horizontal adduction, internal rotation, the humeral head comes out the back. So get a feel for what the normal side is and then the injured side. We don't want to make them too tight. This is the advances that have occurred. This is a one-time dislocator. There are some people who have a significant Hill-Sachs lesion and articular cartilage injury to the glenoid, one-time dislocation. So good reason where MRI scans are very important acutely, so we don't let this individual go back to a contact sport. Fix him early and fix him arthroscopically, and you'll be much more successful than letting him come out numerous times. So here's the coracoid, here's the glenoid. That's our abnormal anterior labrum. And then here's the Hill-Sachs lesion. Correlating with this, this is the Hill-Sachs lesion. Posterior capsule looked okay. Hill-Sachs lesion because the humeral head came out the front, so this is engaging, and the posterolateral bone bruising is consistent with an anterior dislocation. Unfortunately, this individual also had an injury to the glenoid side. This can be debrided and microfractured. Back here, acutely, we usually just leave this alone. If it's a very large Hill-Sachs lesion or engaging Hill-Sachs lesion, chronic injury associated with glenoid deficiency or pair deformity, as described by Stephen Bankart, having anterior inferior bone loss, then that needs to be fixed with a bony procedure such as a Latarjet, and other things can be done for a large Hill-Sachs lesion of remplissage, putting the infraspinatus into that defect. Fortunately, this individual did fine with an arthroscopic stabilization. This is an open arthrotomy doing a capsularrhaphy in this multiple dislocated anterior instability. So here's the humeral head. This is a great retractor, self-retaining retractor. So you can really see, you can do these procedures putting your anchors in arthroscopically to start off with, but this is a repair being done off the glenoid, and then the shift is done as described by Neer and others to shift the capsule. So repair it back to the glenoid and shift the capsule to make an anterior stable capsule. So this is what the open looks like. This was actually taking down the subscap. Subscap can also be split. So subscap is repaired anatomically. Capsule is shifted. Know about these open techniques. We have jumped, it seems, to doing more bony procedures, Latarjets, some of which are easy to do in some people's hands arthroscopically. Others have to do it in an open way. But remember the open capsular repair of the Bankart back to the glenoid, and know how to do a shift anteriorly. Think about doing that in a failed arthroscopic stabilization procedure or the multiple dislocated shoulder. This is a picture of Einar Eriksson. He has the blue shirt on. With him is Per Renström, Philippe Naret, and John Bergfield at the ACL study group in Sweden in 2016. I've had the pleasure of knowing Dr. Eriksson over the years. He was very entrepreneurial as far as getting sports medicine started in Sweden. He has written numerous articles. He started the European Knee and Shoulder Societies and was longtime editor of European Knee Sports Medicine Journal. He is from the Karolinska Hospital in Sweden, and he always states when he is at meetings talking to us Americans, if you Americans would read the European literature, you would know the history of orthopedic procedures, and this is importantly true through the generations. So 25 years, we may be repeating some same mistakes of previous surgeons, so we do need to look back at the literature and know the history of orthopedic procedures and what worked and what didn't work. Certainly over-constraining is a bad thing. So what about back to video? We've looked at arthroscopes with bad images. The development of video has really helped in our understanding of mechanism injury, what we find at the time of arthroscopy, and also how to do arthroscopic techniques. So video is winning out certainly over stills. This is a picture of Thomas Edison, who is credited by us Americans as being the original inventor of the video. The kinetographed patent, or the kinescope, or the peephole viewer. Edison had lots of patents, and he patented this in 1891. Now across the pond, the French credit the Lumiere brothers as the cinematography patent in 1895. And this is Auguste and Louis Lumiere from France. A little across the pond competition. This is a presentation at the ISICOS meeting 2015 in Lyon, France. Mr. Fromeau talked about the history of video and sport and brought some very interesting old clips of soccer games, or football as they call it in Europe. He is the director of the Cannes Film Festival.
And look at this film. So I will mention some words about Euro 2016. So this is the first film about football, about soccer. So look at the ball and forget it now, because they put the ball out of the screen. So you have now to guess where the ball is, watching the movement, the choreography of this group of people.
This is a pride of lions in Botswana that I filmed from an open vehicle. The lions were not hungry because they just feasted, weren't interested in us humans. But look at a difference, what the still on the left and the video on the right. Much more effective to see the emotions and what's going on with these lions. Very happy and full lions, I must admit. On the right with the sizzling, so to speak, water, and on the left with the still water. So video wins in this case, I think. These are some pictures that I've taken of nature, wild horses at Cumberland Island. And I think in life we need to find passion, and if you find passion in photography, follow that passion, or whatever your passion is, whether it's working out, running, drawing, music. Follow your passion and take a little time off from your work to fill your passion jar. What about cameras? $1,000,000 question, so to speak. I've had a lot of SLR cameras, and now it seems like whether it's education of orthopedic residents or pictures or video, cell phones went out. They're with you all the time. It'll be interesting to see the development of the camera and how many of us will still use these SLR cameras. There is nothing like looking if you want to find something. J.R.R. Tolkien. Look at the advances. This company, Post-Time Audiovisual, is in Lexington. My husband is the owner. And think about some of these applications of VR in our education process and development of newer tools that we can use. This was the grand opening of Post-Time Audiovisual. You got to keep up. This is my website. If you'd like to go to the website, it has presentations and publications, web links, other readings, and some of my passion of photography is on there too. So enjoy. Website